Ladies and gentlemen, welcome to the Tang Prize Lecture at EB 2022. I am Xu Qian of University of California, San Diego. I'm also president of the Tang Prize Selection Committee. It's my pleasure and privilege to introduce the Tang Prize and the Tang Prize Lecture today. The Tang Prize was established by Dr. Samuel Yin-Liang Yin, founder and chairman of the board of the Tang Prize Foundation, as an international biennial award that honors and encourages innovative research in 4 fields, namely sustainable development, biopharmaceutical science, sinology, and rule of law. The Tang Prize is rooted in the cultural traditions of Chinese philosophical thinking and in an outlook of convergence and mutual enrichment with other traditions. It aims to promote outstanding research, bring about positive changes to the global community, and create a brighter future for all humanity. The Tang Prize in Biopharmaceutical Science recognizes original biomedical science and pharmaceutical research that has led to significant advances towards prevention, diagnosis, and treatment of major human diseases and improvement of human health. The Tang Prize lectures at experimental biology started in 2014 following the signing of an agreement between the foundation and the EB to present Tang Prize lectures by biopharmaceutical laureates at EB meetings, starting in 2015 with the first lecture by Dr. James Allison, and subsequently every year. These lectures are so excellent in quality that EB made it the plenary lecture for all the societies so that all the attendees were joined at this lecture at the beginning of the EB meeting. The 2014 laureates of the Tang Prize are Drs. James Allison and Tazuko Hongjo. They gave the EB lectures in 2015 and 2016 respectively. In 2016, the laureates are Drs. Emmanuel Carpentier, Jennifer Doadna, and Fan Zhang. And Drs. Carpentier and Zhang give the EB lectures in 2017 and 2018. Because the scheduling issue, we cannot have everyone giving the lectures. It is to be noted that 4 of the 5 Tang laureates went on to receive the Nobel Prize several years later. This is a remarkable success of the Tang Prize. In 2018, the laureates are Drs. Brian Drucker, Anthony Hunter, and John Manderson, with Drs. Drucker and Hunter give the lectures in 2019 and 2021, respectively. The laureates in 2020 are Drs. Charles Dinarello, Mark Feldman, and Tadamitsu Kishimoto. Dr. Dinarello will give the Tang Prize lecture at EB 2022. This EB meeting will be the last EB meeting, so this is a grand finale by Dr. Dinarello. Professor Dinarello received his AB magna cum laude from Boston University, his MD from Yale University. He is a professor of medicine and immunology at the University of Colorado and professor of experimental medicine at Radboud University in the Netherlands. He is also a distinguished university professor at the University of Colorado. Dr. Dinarello has received many awards and honors, and some of them are listed here, including the Ernst Jung Prize, the Ludwig Heilmeyer Gold Medal, the International Chiron Prize, the Karl Nachman Prize, the Piso Prize, Clifford Prize, Paul Ehrlich Prize, Novartis Prize, Munazunka Award, Lifetime Achievement Award, Drexel Prize, Cerami Prize, and the Tang Prize. Dr. Dinarello is one of the founding fathers of cytokines. He purified the interleukin-1 beta protein, characterized its multiple activities, and cloned the gene encoding IL-1 beta. He discovered the IL-1 receptor antagonist IL-1 RA, which can block the biological activities of IL-1, and established IL-1 as a mediator for inflammation. His pioneering contributions led to the FDA approval of recombinant of IL-1 RA, that is Anakinra, for treating rheumatoid arthritis and other inflammatory diseases. It is very exciting to note that Anakinra was recently approved for treating COVID-19. It gives me a great pleasure and privilege to present to you Professor Charles Dinarello to give the Tang Prize Lecture at EB 2022 with the title of Treating Inflammation with Interleukin-1 Blocking Biologics from Gout to Cancer. Dr. Dinarello, please.
This is Charles Dinarello, Professor of Medicine and Immunology at the University of Colorado. I'm very grateful to the Tang Foundation that was instrumental in inviting me to this annual meeting of experimental biology in Philadelphia. However, I'm not able to be present in Philadelphia today, but my presentation is being filmed and will be available to all who register for this meeting. I'm going to talk about the interleukin-1 family, particularly about interleukin-1 beta. My presentation is focused on the clinical development of biologics that inhibit IL-1. The presentation begins with a short background of IL-1 that begins in 1943, the year I was born. I believe this is an interesting topic, historical background, because it is also the beginning of what we now call cytokine biology. After this historical background, I present the spectrum of inflammatory diseases that are controlled with IL-1 blocking therapies. These diseases range from acute attacks of painful gout to the treatment of cancer. Because of the tragic number of deaths due to COVID-19, several biologics have been used to treat COVID-19, and blocking IL-1 activity is high on the list. In fact, the European Medicines Agency approved Anakinra to block the IL-1 receptor and to prevent hospitalizations, respiratory failure, and death. I end this presentation with the future of blocking IL-1 therapies, including oral therapies based on an intracellular complex called NLRP3. Thank you for your attention. The history of interleukin-1. Starting in 1943, physicians predicted that there is an endogenous fever-producing protein. They called it endogenous pyrogen from the Greek word for heat. It was also called leukocytic pyrogen because it came from leukocytes. The endogenous fever-producing protein would help physicians understand fevers in patients who did not have infections. Isolation and purification of the endogenous fever-producing protein would be necessary. What was its structure? How did it produce fever? In 1971, we started to purify leukocytic pyrogen from human white blood cells. In 1974, during the early steps of the purification, we discovered that there were two IL-1s with two isotopic focusing points. As you can see on the right, we measured fever, and on the left, we measured the pH. A molecule that now we call IL-1 beta had an isotopic focusing point about 6.8 to 7, whereas the more acidic form, with a pI of 5.1, had a pI of 5.1. The next step was to purify the molecule. And as you can see from this slide, In the upper left-hand corner, the crude preparations contain many, many proteins. But we had made an antibody to interleukin-1, probably the first anti-cytokine antibody, and that facilitated purification greatly. As you can see on the lower right-hand corner, after isotope focusing, we had a pure protein. It took 6 years to get to that point. In 1977, we published in the Proceedings of the National Academy of Sciences, communicated by Chris Amundsen, that human leukocytic pyrogen was purified and caused fever at 10 nanograms per kilogram. 1977, a protein that would cause fever in rabbits, we use rabbits for this assay, of 10 nanograms per kilogram was unheard of. And many people criticized us that we had not purified leukocytic pyrogen, but we had bacterial contamination. That was not the case. In 1984, we had made a lot of advances on what this leukocytic pyrogen would do, in vitro and in vivo. It had different names. Some people called it endogenous pyrogen, some people called it endogenous mediator, some people called it lymphocyte activating factor, and others called it mononuclear cell factor. We lopped them all together and called them interleukin-1. And as you can see from this slide, on the hypothalamus, it caused fever because of COX-2. In the bone marrow, it released neutrophils. Neutrophils became activated, something we now look at and call interleukin-8. In the liver, it would induce acute phase proteins, and that was because interleukin-1 induced interleukin-6. On T cells and B cells, it was very potent in activating function. For antibody production, you needed IL-1 for antibody production. And all of this came together, would come together, if we had the cDNA, if we had the clone, if we knew what the structure was. So in 1982, we started a project to clone this gene for interleukin-1, particularly interleukin-1 beta. This was published in 1984, the last edition of the Proceedings of the National Academy of Sciences, with the nucleotide sequence of human monocyte interleukin-1. This was the precursor. We had a very large protein that we later would call the precursor. What happened next is actually the beginning of cytokine biology, because we had recombinant interleukin-1. We had recombinant human interleukin-1 beta. And this is what we found using the recombinant protein, that there was all these biological activities: metabolic, physiologic, inflammatory, hematologic, and immunologic. And so this really becomes cytokine biology, with the ability to make recombinant interleukin-1 and test it in animals and in vitro. The next step was actually relatively important, and that was to inject humans with interleukin-1, either IL-1 alpha or IL-1 beta. The interleukin-1 alpha was cloned by the Hoffman-La Roche scientist, Peter Lomedico. We had focused on the cDNA for human IL-1 beta, but both of them produce fever. As you can see, in humans, fever was produced between 1 and 10 nanograms per kilogram. These patients felt myalgias and joint pain, fatigue. In the blood, the neutrophils were elevated. They complained of headache, and at higher doses, 30 nanograms per kilogram, they had gastrointestinal discomfort and hypotension, blood pressure went. And then when they increased the dose to 300 nanograms, these patients went into hemodynamic shock. You may want to ask the question, why were we injecting people with recombinant interleukin-1 that was so inflammatory, that caused all these symptoms? It was because during this time in cytokine biology, people were very interested in treating cancer to increase the immune system for cancer. And so these were all cancer patients. But within a few months of these studies, we stopped injecting people with interleukin-1 and we focused on blocking IL-1. And so interleukin-1 never was used to treat patients to increase the immune system. And everything now focused on blocking IL-1. How does IL-1 induce inflammation? The first step is that IL-1 alpha or beta will bind to the type 1 receptor, and the type 1 receptor is present on most cells, and this activates the receptor to go a conformational change, and that attracts receptor 3, which is the co-receptor. And receptor 3 then migrates and forms a dimer. That dimer approximates the intracellular part of the molecule, and you have an area in the intracellular molecule called the told IL-1 receptor domain. It's shown in this slide by red. And that attracts other kinases, particularly MYD88, to the intracellular part of the molecule. And this activates the cell to produce inflammation. What happens next is you look at what actually takes place with the activation of the type 1 and the type 3 receptors. In the nucleus, we see a very strong signal for new gene expression. And you can see from this slide that these genes are genes that are associated with disease, not with health. So we see cytokines and cytokine receptors. We have observed a variety of other molecules that are increased with this. Release of bone marrow leukocytes, chemokines and their receptors. In addition, we see adhesion molecules on endothelial cells. We see phospholipase A2 and similar activating parts of the molecule, including COX-2 and nitric oxide synthase. What does that actually result in? It results in a series of physiologic changes that we recognize as disease. For example, we have systemic inflammation, and there's local inflammation. And then we have the most important of all of this is decreased pain threshold. And in the patients that are subjected or develop inflammatory diseases, we have a cellular infiltration that actually results in reduction in functionality. And the reduction in functionality we read often as a loss of function. Now, nature gave us an antagonist, a blocker, a natural blocker, which we call the interleukin-1 receptor antagonist. And that is shown in this diagram in the upper right-hand corner. IL-1 receptor antagonist will block the type 1 receptor. It will actually bind to the type receptor. And there is no dimerization of the type 3 receptor, so there's no inflammation. Without the dimerization of the type 1 and the type 3 receptor, there is no inflammation. Now, we've spoken quite a bit about interleukin-1 beta, but interleukin-1 beta is only one of the entire interleukin-1 family. And shown in this slide is the interleukin-1 family is divided pretty much equally in the pro-inflammatory cytokines shown in red dots and the anti-inflammatory cytokines shown in green spots. Now, they all related to a particularly part of the molecule called the IL-1 family consensus sequence, which is 3 amino acids that the entire family shares and is used to process the molecules. IL-1 receptor antagonist is unique It does not, it's anti-inflammatory, but it does not have the AXD signature. Now, I would like to discuss blocking interleukin-1 from gout to cancer, particularly the clinical application of IL-1 blockade. Available to study in human disease is Anakinra. You just saw the slide showing that IL-1 receptor antagonist, which is the natural molecule, Anakinra is a recombinant form, that is approved for use in humans and is produced by the Swedish orphan Biovitrum. In addition, we have antibodies to IL-1 beta called Canakinumab, which neutralizes IL-1 beta, and it's approved for use. It's produced by Novartis. There's another anti-IL-1 beta that's produced by Zoma, and it's owned by Novartis, but it's not approved yet. Then we have, in addition, soluble receptors called rilonacept, which is also approved by Regeneron. It neutralizes IL-1 beta and IL-1 alpha. Now we have anti-IL-1 alpha, which neutralizes interleukin-1 alpha, but has no effect on interleukin-1 beta. Ex-Biotech has now licensed anti-IL-1 alpha to J&J. In addition, we now have an antibody that blocks the receptor 3, the co-receptor, and this is a discovery by MAB, discovery of monoclonal antibodies, and is licensed to Santa Fe. Another company from Sweden as approval as an orphan status of anti-receptor 3 for pancreatic cancer. As you can see from the slide, what's in yellow is approved, but there are other important aspects of blocking IL-1 that are now in studies. And I'm going to talk later on about the PANSER trial, a specific NLRP3 oral inhibitor. This will be the first time we have a pill to treat inflammatory diseases. Chronic inflammatory diseases responsive to IL-1 therapy. There is a small number, but a very important number, of hereditary diseases that are due to mutations that result in the loss of control of IL-1 beta secretion. These are rare diseases, but they're very important because the clinical manifestations are very dramatic. Then there's another group of diseases, chronic inflammatory diseases with no known genetic explanation. But what's really interesting is the common acute and chronic inflammatory diseases that we now treat with IL-1 blockade. Top of the list is refractory gout attacks. These are very common, particularly these days with obesity and overnutrition. There's more gout attacks, and it's become a very serious problem for diabetics particularly. In addition, we have post-myocardial infarction remodel, or heart failure that takes place after someone has a heart attack. And then we have decompensated heart failure. That's part of the post-myocardial infarction syndrome. We have control of type 2 diabetes, very important type 2 diabetes that is actually mediated by IL-1. And so we block with IL-1 and we treat type 2 diabetes. You'll see that soon. And then we also have insulin resistance, a serious problem, not only for type 2 diabetes, but also type 1 diabetes. And we also have dry eye disease. It's a serious problem in some environments, particularly in Colorado where I live. It's a very common disease because of the dry air. And then we have autoimmune hearing loss, particularly becoming a problem as we get older. And most importantly, the new frontier is going to be cancer. Going on now, the type 2 diabetic is treated with IL-1 receptor antagonists, and you can see from this slide the type 2 diabetic, beta cells that produce the insulin are very high in terms of messenger RNA for RNA as compared to the beta cells from non-diabetic patients. And here's a study that was published in the New England Journal of Medicine showing the comparison of placebo versus Anakinra for the reduction of C-reactive protein, which is a measure of inflammation, and the reduction of interleukin-6, which is also a measure of inflammation. So here we have real solid proof that you can use Anakinra, it blocks the IL-1 receptor 1, and see a reduction in 2 mediators of systemic inflammation. Now, going on to the common problem of gout attacks, you can see from the slide, this inflammatory joints. Most gout attacks are actually in the large toe because of the dependency in the large toe, and you have accumulation of inflammation. But it's also observed in joints, and particularly in the hand and other joints. And gout, as I said recently, is a terribly disease in terms of pain, and it's becoming a very serious problem in terms of modulation of other aspects. People who have gout have other diseases, particularly diabetes, and they tend to get more inflammation. And so gout is a way of reading out an inflammatory system, not only in the joints, but also systemically. Here is a study that was published comparing the antibody to Canakinumab, which neutralizes IL-1 beta, and you can see that's the solid circles, compared to a commonly used steroid that is used to reduce the inflammation of an acute gout attack. And you can see from the curves that Canakinumab, which inhibits IL-1 beta, is very effective. We'll talk more about gout attacks later on in this talk. Now I want to go on to ischemic diseases. What are ischemic diseases? Well, top of the list, I think most people recognize, is a heart attack. That's due to ischemia in the heart. But another ischemic disease is stroke, and that is ischemia in the brain, clotting of a small artery. There's also ischemic diseases in the liver, and ischemic diseases that occurs also in gastrointestinal tract when there's a blockage. It's a huge field, ischemic diseases. What happens in a heart attack, for example, as an example of an ischemic disease? So here is a study, but my very dear friend and colleague, Antonio Abate, post-myocardial infarction. It's after somebody has a heart attack, what happens to the heart? So here is one of his many studies, one of many Antonio Abate's studies. Here is what happens in a heart attack. The patient is brought to the emergency room with crushing chest pain, and the diagnosis of what's called ST-elevated myocardial infarction, which is called STEMI on this slide, brought to the catheterization lab, and the catheter is placed, and they demonstrate that there is a blockage. And then they reduce the blockage, and the artery opens up, and the patient is saved. This is a life-saving procedure. Now, that heart attack, however, has caused damage. And what Antonio Abate did was soon after the STEMI heart attack and the stenting, or the opening of the artery and placing a stent to open up the artery, Anakinra is administered, 100 milligrams subcutaneously for 14 days. But the patient's heart sustained an ischemic event. In some of these patients, even they were stented, will develop heart failure. And those are now going to be compared to those who were treated after the heart attack, after the stenting, with Anakinra. And shown on this slide, what happens. On the left-hand side, you can see the placebo. These are people that had a heart attack, were treated with a stent, but did not receive Anakinra. They were given a placebo for 2 weeks, and you can see at day 3, 72 hours after the heart attack, there is a highly significant increase in CRP, which is an indication of inflammation. However, on the right-hand side, you can see that the patient treated with Anakinra for 2 weeks at 72-hour time point, there is no inflammation. There is no CRP. Now, if we go back and look at some of the studies that were done and just look at the group that got Anakinra after their heart attack, and you look on the left-hand side, you can see heart failure as a readout. That's heart failure and free survival, that only 5% developed heart failure that were treated with Anakinra compared to 30% for placebo. I will soon talk about another aspect of blocking IL-1 beta and heart attacks soon, but try to remember this statistic, that you can reduce heart failure in patients who were treated after a heart attack with Anakinra. Now what happens next? People who have various reasons for having cardiovascular disease, diet, overnutrition, variety of reasons becoming a huge problem, obesity and overnutrition and heart disease and heart attacks, it's still the major killer. It's still the major killer in the world. It's not only related to the United States and Europe. It's still the major killer, a heart attack. And this study was designed to block IL-1 beta with an antibody, Canakinumab, in a huge worldwide trial called the CANTOS trial, C-A-N-T-O-S. And the CANTOS trial tested 3 doses of Canakinumab, initially designed to look at 17,000 patients. 17,000 patients is a huge number, but it was reduced to 10,000 because there was a significant number of heart attacks that were available to study. And it was the concept that patients who had one heart attack had a high risk of a second heart attack. And that was the design of the trial. And here is the actual title page that appeared in the New England Journal about 3 years ago. The anti-inflammatory therapy of Canakinumab, that's the antibody to IL-1 beta, in atherosclerotic disease. And here is the design of the study. An injection of Canakinumab was given 4 times a year for 4 years. It's obviously a very long trial, but it's an important trial for many reasons. So you can see in the top, each arrow is an injection of Canakinumab for year 1, 2, 3, and 4. And you can see from the bottom graph this dramatic reduction in CRP levels within 3 months compared to the placebo. And it's a dose response. Obviously, the high dose of 300 milligrams 4 times a year had the greatest drop in CRP. So this is a placebo-controlled randomized trial showing the efficacy of Canakinumab to reduce CRP in patients who have had one heart attack and are now at risk for a second heart attack. In that trial, as you can see here, all the doses, whether it was the low dose, 100, the medium dose, 150, or the high dose, 300 milligrams, everybody benefited from the primary endpoint of a second heart attack. And then shown on the next slide, you can see what happens to all the other aspects of cardiovascular disease. The visits to the emergency room, the stenting, the number of cardiovascular events, visits to the emergency room. This antibody was remarkable, and it really proved something that we all have studied many times in mice and in vitro that blocking IL-1 would reduce progression in atherosclerotic disease and eventually would reduce the number of heart attacks. Now, what was most important in this study was something that some of us in IL-1 research would hope would happen, but in fact did. And in these patients, when they began the trial, they did not have cancer. In fact, if you had cancer or any early sign of cancer, you could not participate in this trial. So those 10,000 people who were screened and entered the CANTOS trial had no evidence of cancer at the time they entered the trial. But some of them were obviously at risk, and that was because they were smokers. And so there was a large number of smokers in this trial. It was a worldwide trial. As you know, in some parts of the world, smoking is very high, and that contributed to lung cancer. And so this is what happens in this trial. That the interleukin-1 beta antibody, Canakinumab, reduced the incidence of lung cancer on patients who were in the trial for atherosclerosis. And this was, like the CANTOS trial itself, the same group of people. It's not a new group of people, the exact same number of people that were in the trial. And now you can see what happens. I think everybody got so excited when they saw this. This is the non-cardiovascular benefits of the CANTOS trial and cancer mortality. This is all cancer mortality. You can see the placebo in the dark line, and you can see the dose response with the reduction in cancer mortality, all mortality of 51%, death from any cancer. Just take a look at that. If you now look specifically at what happens to lung cancer, you have a 67% reduction in the incidence of lung cancer, highly significant, against a dose-response curve. And then if you look again at another aspect of this trial, there's a 77% reduction in fatal lung cancer, death. And so this trial, which went over 4 years, clearly showed that you could reduce lung cancer significantly by treating with IL-1 beta. Now, when you interpret this data, you have to consider the fact that once these people had a diagnosis of lung cancer, for example, they no longer received Canakinumab. That's right. Once you have a diagnosis of cancer, you are dropped out of the atherosclerosis trial. And you don't go to see a cardiologist, you go to an oncologist to treat the cancer. So some of these people didn't have all 4 years of Canakinumab. They've all had 1 or 2 years. But the effect is dramatic, as you can see. Now I want to go on to IL-1 Alpha blockade. We've not talked too much about interleukin-1 alpha blockade, but it's a very important molecule, and it's very important for many reasons. But I want to just focus again on cancer. So IL-1 alpha was studied in a double-blind, placebo-controlled phase 3 trial with advanced colorectal cancer. Now, what does advanced colorectal cancer really mean? It usually means the people are going to die because it's advanced and it's metastatic. And so this is an end-of-life type of study. And it was designed primarily to decrease what happens to these people who have metastatic colorectal cancer. They have pain and fatigue, and their quality of life is very poor. Now, what happens in this trial is these people were enrolled. And this was a very unique trial because it was placebo-controlled. You often do not do placebo-controlled trials in cancer, but this was a phase 3 placebo-controlled trial using something called the DEXA scan, which is a way of measuring lean body mass. And we all know that people with cancer, terminal cancer, lose weight, and that's part of their death. So here is actually the design of the trial. You can see that they were treated with 4 treatments every 2 weeks of this antibody to IL-1 alpha. So you can see treatment at beginning at 2 weeks, 4 weeks, and 6 weeks. And then after the 4th dose, we looked at the assessment and the outcome. And shown on this slide is all the objective, and these are not subjective, but the objective criteria comparing the placebo. And you can see that interleukin-6 goes down. And because it was placebo-controlled and blinded, these are objective criteria. So it's a highly anti-inflammatory result in these patients. How did that affect the quality of life of these patients? Well, here's an example. Here's the people who had the endpoint, which is the lean body mass endpoint, who met the criteria, and this is their overall survival at 6 months. And you can see a highly significant increase of almost a year compared to 4 months for surviving and avoiding death. And here's another way of looking at the data, that these people actually came to less time in the hospital, and all the other aspects of this type of treatment to reduce the difficulties that they encounter with essentially a lethal disease. So what do we conclude? At this point, we conclude the following. Blocking IL-1, either IL-1 Alpha or beta with Anakinra, rilonacept, anti-IL-1 beta or anti-IL-1 alpha, is an effective and in rare as well as common inflammatory diseases. I'll talk about COVID-19 shortly. We also conclude from these studies that blocking IL-1, either IL-1 alpha or beta in cancer, is a new frontier in biology, and several trials are underway. And we also conclude from these studies that although parenteral therapy with anti-IL-1 is effective in inflammatory diseases as well as in patients with cancer, that orally active, safe, specific inhibitors of the NLRP3 inflammasome can be effective as parenteral therapy with anti-IL-1 beta. And I'm going to talk about that very soon. Now I want to go on to the actual inflammasome itself. The inflammasome is a very complex intracellular molecule, and it stands for nucleotide binding domain leucine-rich repeat pyrin protein containing 3. Very long way of talking about it, so we use the short NLRP3. Or sometimes we just use the inflammasome, the IL-1 beta inflammasome. This is what it looks like. It's NLRP3, sometimes we call cryopyrin. It's a very complex molecule, and it makes associations with other parts of the inflammasome, and this all activates pro-caspase-1, and that's the first step in making IL-1 beta. So as you can see on this slide, the active caspase-1 is a heterodimer, and what does it do? It takes the inactive IL-1 beta precursor and cuts the N-terminal precursor to activate the molecule, and it becomes an active cytokine, IL-1 beta. You can see this is the cleavage point here of caspase-1 that cuts the molecule, and then the active part of the molecule, the carboxy terminus of the molecule, is released from the cell. Now what happens with this NLRP3 inhibitor? Well, the first thing we did was look at IL-1 beta in melanoma. Melanoma is a terrible cancer, and we looked at this in a mouse model of melanoma. And we published this. The targeting tumor-derived NLRP3 reduces melanoma progression by limiting myeloid-derived suppressor cell expansion. That's a IL-1 beta-mediated inflammatory process. And we also did something I think is actually very new these days, and that's combining a checkpoint inhibitor such as anti-PD-1, which is commonly used for cancer, with the Japan's trial OLT-1177. As you can see, the combination of the checkpoint inhibitor anti-PD-1 with NLRP3 inhibition really has the lowest size of the tumor. And so this becomes a new area in cancer therapy, and that is to use a checkpoint inhibitor such as anti-PD-1 with an NLRP3 inhibitor such as OLT-1177. Now, what happens in a society now that is subjected to a pandemic, and a society that was not prepared for this, a society that rapidly spread and caused the tragic death of so many people. And I just want to personally say that these people did not have to die. And it's a miserable death, I must say. So everybody was very interested in the pathogenesis of COVID-19. And could molecules like IL-1 be important? So this is what we did. Early on, with one of my French postdocs, we did this very early trial, showing that if you use Anakinra, which blocks the IL-1 receptor, you would reduce the hospitalizations, the duration of the disease, as well as death. And on the slide, you can see on the left and the right. But it was not controlled. This was not a controlled trial. It was just a desperate attempt to reduce the inflammation. Now what happens next is people started to look at this Anakinra, and now the good news is that Anakinra is approved for COVID-19 treatment by the European Medicines Agency. And the approval was based upon a very important trial, placebo-controlled, blinded, randomized phase 3 trial that was carried out in Greece, actually, by a very fine collaborator that we've worked with many years with. And it was published in Nature Medicine, a highly prestigious journal. Here is what the secret of this whole trial is about. It was to use something called soluble urokinase plasminogen activator receptor. That was a marker, a biomarker of inflammation. It wasn't specific for COVID-19, it was a non-specific. And here you can see the results. Here on the left is the placebo-controlled 189 patients, and on the right is the Anakinra 400 patients. You can see the difference, fully recovered, asymptomatic, symptomatic, hospitalizations, mechanical ventilation, all significantly lower than the placebo-controlled patients. And that's why this was approved. So this becomes a big step in COVID-19 that you could, with intramuscular injection of 100 milligrams a day of Anakinra, have fully recovered patients, reductions in death, and reductions in hospitalizations. Now, what is the future blocking IL-1? Parenteral biologics are now available. Parenteral biologics have to be injected. Many patients don't like needles, and we know this, but nevertheless, they're very effective therapies. So you have the biologics that are injectables, they're parenteral. There's Anakinra for blocking the IL-1 receptor, Canakinumab for neutralization of IL-1 beta, rilonacept for soluble receptor, and bermekimab for neutralization of IL-1 alpha. Now, what is new? That the future is oral biologics. And top of the list is the NLRP3 specific inhibition, and that is now one specific one that we know about and we work on was OLT-1177. That's also called the PANSER trial. Now here is the trial that was carried out, of DEPANCER trial, which is the oral selective NLRP3 inhibitor, which was used to treat gout flares. This was an open label, dose-adapted proof of concept trial. And you can see that there were 4 doses, 100 milligrams every day, 300 milligrams, 1,000 milligrams, and 2,000 milligrams. And you can see that there is, on the 100 milligrams, which is a low dose, you can see mostly red, and you can see increasing numbers of greens and yellows as you move to the high doses of 2,000 milligrams. And this is a measurement of joint redness and heat and tenderness. And you can see in the bottom graph on the left, the dose response, beautiful dose response, a reduction in joint tenderness, and on the right-hand graph, reduction in joint swelling. There's less pain. Now, if you look at this trial in a little bit type of detail and measure IL-1 beta, you can see the 100 milligram dose in the upper graph, left-hand graph, there's really no significant change. When you go to the 300 milligram dose, you can see a reduction, 70%, and then at the 1,000 milligram dose, increasing, and then when you get to 2,000 milligrams, you get over 55%. That's the plasma circulating IL-1 beta. What happens inside the cell? If you look inside the cell, you see something really quite remarkable. On the left is the 100 milligram dose, which really did not have any effect on reducing IL-1 beta in the circulation and did not really have very much of an effect in terms of efficacy. On the right is the 200,000 milligram dose. It compares day 0 with day 3. Day 3 is the primary endpoint. Does pain come down on day 3? Does swelling come down? And the answer is yes, with the DEPANCER trial. As you can see, there's really no change on day 3 with active IL-1 beta, and the pro IL-1 beta doesn't change significantly. However, the 2,000 milligram dose clearly shows a highly significant reduction on day 3 of active IL-1, whereas the precursor has not changed. So this is actually the proof that the DEPANCER trial, the specific inhibitor of the IL-1 beta inflammasome, works not only in the circulation IL-1 beta, but inside the cell. And the critical cell of this, of course, is the monocyte that is a major source of IL-1 beta for this trial. Now, the other aspect that we have is the randomized trial of DEPANCER trial in patients with systolic heart failure. Now, remember, we've gone all this over the stuff of systolic heart failure after a heart attack. So these people have they've had a heart attack. Maybe they've had more than one. And now they have systolic heart failure. What does systolic heart failure mean? They can't exercise, they can't have a normal life. It's very unpleasant to have systolic heart failure. And this trial was done in patients who were already being treated with the standard of therapy. And just look what happened. You can see that the high dose, the top dose of 2,000 milligrams, has an increase in what's called left ventricular ejection fraction. That's the amount of blood that can be pumped out of the left ventricle into the circulation. And this worked with the high dose and all doses. And this was statistically significant. In addition, these patients were given exercise test. And you can see from the increased exercise test that there was a significant increase. So this translates to the quality of life that is accomplished by using the NLRP3 inhibitor DEPANCER trial. Now, this is the first trial, and I'm sure there'll be many trials using DEPANCER trial in people who do have heart failure as it becomes an increasing problem and affects the quality of life of so many patients. Well, I hope you enjoyed the presentation. I certainly enjoyed telling you all this wonderful data and the future of blocking IL-1. It's been a very positive experience for me personally to be able to tell people about the exciting things that's happening in IL-1, particularly the fact that we have a pill now, and we don't have to inject everybody. But we'll still probably have to inject people because of the importance of some of these pathways. But I think the future of cytokine biology, which sort of like begins with IL-1, has a huge future. And I hope that some of those listening to my presentation will be motivated to think about the importance of cytokine biology during this meeting of experimental biology. And thank you again for your attention.